already been given. Oops. So the aim of my presentation is to present to you the Israeli project with Oncotype DX testing in colon cancer. And as I promised, I will skip all the slides that have the background information. Now, this is the first manuscript that is going to be submitted within the next week. And as you can see here already, most of you are partnering in this project. We have here authors from 11 institutions, as well as our partners from Oncotype and from the Clalit Health Services community department. And I will discuss now this study. So as we all know, we are dealing with a very common disease, and going directly to the bottom line, we need better ways to identify the patients that may benefit from adjuvant treatment in stage 2 colon cancer. And we heard now about the test itself, and the aim of the current study was to evaluate the impact of this 12-gene assay on the treatment decision-making for T3 MMR proficient stage 2 colon cancer in patients in a conventional clinical practice setting within the Clalit Health Services. Now, a lot of these treatments were given in institutions that do not belong to the Clalit Health Services, but all the patients belong to Clalit Health Services, which sponsored the tests. Now, this is the assay itself, and all the development schema as was just described. So the study design, Clalit Health Services collected the treatment recommendation, as you all know, because most of you participated in the study. So you had to fill up a questionnaire before sending the test. And we also collected the actual treatment that these patients received following the receipt of the test results in stage 2 colon cancer. And the period that I will present here are patients that were enrolled between January of 2011 and May of 2012. Changes in the treatment intensity from the initial recommendation to the actual treatment received were defined as follows. Decreased intensity was defined as changes from to observation or to remove oxaliplatin from the adjuvant treatment if the physician intended to give oxaliplatin. On the other hand, increased intensity was defined as changes from observation to treatment or to add oxaliplatin to 5-FU-based therapy, and no change. Changes in treatment intensity were summarized, as you will see, for the overall population and by recurrence score groups, as defined by the QUASAR study that we saw before. And the analysis, as I mentioned before, were restricted to patients with T3 MMR proficient tumors. And this is the patient disposition. As you can see, during this period, 312 patients were enrolled into the study. We excluded the MMR deficient tumors, and so we ended up with 273 patients. And then we excluded 4 patients that were found not to be eligible. And the eligible patients for the primary analysis were nearly 270 patients, which is almost all the population. Considering clinical and pathological characteristics, as we can see here in the clinical practice, we treat older patients, and then in the studies, the number of lymph nodes examined, all of us reduced the average because in Tel HaShomer, as we heard, it's over 90%, more than 12 nodes. So basically in Israel, we have the data, it's 85% overall in this study population, which is surprisingly well. Obstruction and perforation. Physicians could put patients also, even if they consider them high risk stage 2, they were eligible for this study. So it's 17%. Limb vascular invasion, 6%, slightly lower than the validation studies. High-grade tumors in 7%. And the recurrence score, there was nice separation. Nearly 60% received low scores. And again, this is a continuity. So there is the cutoff of the 30, but this is not magical. And everyone, and I for example, I use the individual score of these patients. I don't use lower than 30 or over 30, but I discuss with the patient the actual risk of recurrence in 3 years. But the separation is similar to the validation studies. So low risk, nearly 60%. There is about a third of the patients that are intermediate, and about 10% that received high scores. Now, this is the main result of the study. We can see here that 38 of the patients received treatment that was different from the treatment defined by their physicians before he had the recurrence score. And similarly to the studies that we just saw from the States, there were more changes on the downside. So 28% of the patients received less treatment or less intensified treatment than as was defined before. And about 10% of the patients received more treatment. And here we can see it's a very similar table to the ones presented before from the two American studies. And we can see here the individual changes in the patients according to the groups. So for example, you can see that from the 60 patients were recommended 5-FU based adjuvant chemotherapy. There's no here. And these patients actually were just followed. So in blue, we see the less intensified treatment. And here we see the increased treatment. So this is 10%, and this is the 28%. If we look at pre-assay treatment recommendations versus the actual treatment, we can see that originally the physicians intended to give chemotherapy to 45% of the patients, but actually only 28% received chemotherapy, whereas observation was planned in 55% of the patients, but actually 72% of the patients were just observed. If we look at the recurrence scores, we see, as we can expect, that mostly in the lower or in the low risk, there's higher percentage of patients that received less treatment than intended. And again, inconsistent with this, we can see that in the high-risk group, these are most of the patients that received more intensified treatment. That means that the physicians actually could rely on the results of the test. And these are the changes in chemotherapy according to the risk groups. And we can see here in the low risk that nearly 50% of these patients were planned to receive chemotherapy, but actually only 14% received it after they received the results. On the opposite, in the high-risk group, whereas only 40% of the patients were planned to receive chemotherapy, in fact, 60% of them received chemotherapy after receiving the results. And very nicely, when patients were in the intermediate risk, we go back actually to the individual perspective on adjuvant chemotherapy, as we know that not all oncologists share the same view about the benefit or how much it's worthwhile and so on. So basically what we see here that when the oncologist received the result of the test and it was just intermediate score, in between they actually could rely on their original plan for this patient. The actual number I said before, nearly 300. Okay. Here we can see the distribution of the individual patients. And what we can see here that before receiving the test, the recommendations or the scores are distributed quite randomly, as can be expected. There's no nice separation between the planned treatment and the actual risk of the patient, according to the Oncotype test. But when we have the data on the actual treatment received, here we can see that as most of the oncologists relied on these results, there is a nice separation. We can see here that in the observation group, most of the patients had low risk results, although we can see here also patients with few patients with high risk results, but maybe they had comorbidities, severe comorbidities, or they were relatively older. So in spite of these results, they still were only observed. And on the other hand, we can see that in the intermediate group already, in the 5FU groups, sorry, we have scores that are higher, and most of the patients that received oxaliplatin-based treatment, and we know that we give it mostly, some of us at least, give it to very high risk stage 2. So most of these patients, indeed, they had high risk scores in the results. So to summarize this study, this is the first international, that is outside of the US, study to assess the role of the quantitative recurrence risk information provided by the recurrence score result in clinical decision making for stage 2 colon cancer patients with T3 MMR proficient tumors. The actual treatment received post-assay were different from pre-assay recommendations for 38% of the patients, with most changes resulting in less treatment, less intensified treatment. And an overall 17% net reduction in chemotherapy use was observed from 45%, which was planned pre-assay, to 28% of actual chemotherapy received. And the conclusions are that the study is inconsistent with the 2 US studies, but again, it comes from a more European, I would say, environment practice. And these results demonstrate that the impact of Oncotype DX result in real-world clinical practice with substantial change in pre-assay treatment recommendation to post-assay actual treatment received to T3 MMR proficient stage 2 colon cancer patients in Israel. The use of the test may lead to an overall reduction in adjuvant chemotherapy use with a potential decrease, and I emphasize this is still a potential decrease in health care expenditures in this patient population. And the current status of the study, so an abstract was presented at ASCO of last year, and the first manuscript on decision impact analysis, which many of you are partner in this manuscript, is about to be submitted next week after a very long review process among us and also with the company. So it's about to be submitted next week to PLOS ONE. The current database has already, as I mentioned, in this analysis there were less than 300 samples, but now we have about 850 tests, and these are undergoing analysis nowadays. We have data on about 1,300 patients, historical controls that was collected, patients that were treated between 2000 and 2010, and they are undergoing analysis these days. And this is, we have 2 future studies that are planned. One of them has already been initiated, and this is the comparison of the patients that receive treatment with the Oncotype DX studies results and the historical control. So we are going to have a study of nearly 2,500 patients. And then the next one that is planned is on pharmacoeconomics to actually evaluate if indeed we save money by using this study or not. The new study that I want to present, and I presented it about a year ago in the GI group, as a proposal, but now this is an ongoing study already. This is the study in stage 3, and I will skip these slides because you just saw it 10 minutes ago. So this study is planned to include patients with stage 3 colon cancer patient, and the objective is to evaluate the impact of Oncotype DX colon testing on the physician treatment plans. And specifically, we want to ask several questions. What would be the recommended treatment without testing? This is the pre-assay recommendation. What would be the recommended treatment with the testing? This is the actual treatment given. And if oxaliplatin treatment is the preferred treatment in stage 3 colon cancer, how would the recurrence score result impact treatment decisions? And I would like to emphasize that the decision is not only to be or not to be, or to give or not to give oxaliplatin, but in my opinion, it's not less important is how much are you going to insist on a specific treatment. That is, if you are going to give oxaliplatin, maybe you are planning to give a few cycles, for instance, fewer cycles of oxaliplatin. And another option is that there will be no impact. I mean, that is that the physician will write down in the questionnaire that regardless of the results, he will still remain with his initial recommendation. So the status of the study, the first patient was enrolled in December of last year. At present, there are 45 tests that have been done already, and the goal is to have 200 tests before the first analysis of the data, and the estimated accrual time is 2 years. And last week, you all received a new form, new questionnaire form, because the previous form was reviewed, and we came up with several things that need to be modified. And this is the new form that was submitted to all of you. And here you can see in the bottom line, in the bottom part, the options. What would you recommend if you don't have the results? And we added here the options that if you're going to use oxaliplatin, are you going to use 12 cycles of FOLFOX or 8 cycles of Xelox? Because we know that some of us are using Xelox. Or if you're going to use 5-FU and oxaliplatin-based treatment, are you going to use fewer cycles of treatment? And this is also a practice that's done in some places when, let's say, patients have a minimal number of involved nodes, for instance, so you want maybe to decrease the risk of peripheral neuropathy, which we know it correlates very well with the number of cycles. So some people, even in their practice, they reduce the number in these relatively traditionally low-risk patients to, let's say, 10 cycles with oxaliplatin or 9 cycles of oxaliplatin. So are you going to do this strategy to begin with? And how are the scores are going to, and you can see here if you will get any of the 3 optional results, what will be your recommendation at this point? And again, we will not only test what the physicians write in the questionnaires, but what was actually given, because we have all the data in the Clalit database. So thank you.
Thank you so much.
לענות לשאלות עכשיו, ומה אומרת המפקדת?
Yes, maybe we can take 5 minutes for question.
For me. Okay. כן.
Only the percentage. I would like to, if I may, to see the actual numbers because of the numerically you had 269 or 264 patients included in the study, and afterwards you showed us the statistics. I mean, in America you see statistics, but I want to see numbers. I mean, actual numbers of patients.
I gave the numbers.
Yes, but if you
the distribution of the groups was 58% in the lowest.
No, not 58. The absolute number.
You can make 58% out
No,
of 200
can you
and...
show us the
Can. It's Friday morning. I don't want to, to make too much effort. So, but we can
this one. Yeah.
go back to the data.
Not on this. Go further.
Here are the numbers.
Now go further.
100.
Go further a little bit. Okay, here. Here are the numbers. Okay. Thank you.
דני, רצית לשאול משהו?
Your definition for less or more treatment for stage 2 patients was mistaken because you said more oxaliplatin or less oxaliplatin.
No. There was a reduction in the intensity that you planned. For instance, if someone...
Look at your definition.
No. I can go back over it. First of all, it's our definition because you are also partnering in this study. So I'm just presenting it and analyzing.
I am not.
But I have a very comfortable...
I am not. My name is not there.
By the way, I can explain why your name is not there, because the names are according to the number of the patients that you put on the study, and you put some patients on the study because it's available to your Clalit Health Services patients.
Go to the definition.
Okay.
Just go to the definition that you said.
But the definition was if you moved from, and this was what the physician wrote.
Oxaliplatin from the adjuvant. Oxaliplatin is not a standard for T2.
Yes, but if the physician wrote that he intended to give oxaliplatin to this patient, this stage 2 patient, and he actually did not use oxaliplatin, this was a less treatment. Some of the physicians planned to give oxaliplatin.
Okay, in this case, it seems a little bit strange because you said there is a 28% reduction in oxaliplatin treatment.
No, in the treatment. In the treatment, most of the reductions were from 5-FU oxaloda to no treatment. What?
That's not what you say here.
I'll go over the slides. Where? Direct me to the to the slide.
No, really?
I don't know. I don't have to change it. Sorry.
אבל הוא מדבר to remove oxaliplatin.
It's change. Listen. It's change from to observation, or if you planned to give oxali, to remove oxaliplatin from the treatment. If someone moved from oxaliplatin to non-oxaliplatin based, this was also reduction.
Any other questions?
And by the way, you have a better chance in the stage 3 now to put more patients, to put to appear on the paper.
I must say,
because this is still accruing.
First in the paper, according to his.
Okay. Okay.
If we don't have other question, I must say that this is a beautiful collaboration and cooperation of 20 physicians actually, and I don't think in Israel we have too many papers of 20 authors Israeli. So, congratulations! It's a great success for us. Yes, for you. Okay, and.